because it's not easy to do chronic care without having a smartphone.
Welcome to the Business of Healthcare podcast from the Center for Healthcare Leadership and Management. The center is based at the Naveen Jindal School of Management at the University of Texas at Dallas. The show, like the center, brings together business leaders and other forward thinkers to discuss how best to meet the challenges of a rapidly changing, increasingly complex healthcare industry. I'm your host, Dr. Bob Kaiser, Director of the Master's Program in Healthcare Leadership and Management for Professionals. In this edition of the Business of Healthcare podcast, we have Dr. Dan Carlin, founder and CEO of WorldClinic. WorldClinic is a private concierge medicine practice that utilizes telemedicine to care for a diverse client base of organizations, senior executives, and individuals and their families. Their promise is concierge medicine anytime, anywhere. Functioning as a personal virtual emergency room and healthcare concierge, their physicians and care team provide immediate telemedical emergency response and urgent chronic condition management on an on-demand, anytime, anywhere basis. Welcome to the podcast, Dan.
Thank you, Bob. Happy to be here.
When I first started my research on WorldClinic, I was amazed at the scope and functionality that was offered. Concierge medicine, anytime, anywhere. That's a very powerful claim. We have a lot to discuss today, and I wish we had a couple of hours, so let's try to at least cover the tip of the iceberg. The top of the list, your life story. It could be an Indiana Jones movie, so we want to touch base on that. And then next up, how you transition your medical expertise in emergency medicine as an entrepreneur to create and scale WorldClinic. And finally, your future view of virtual medicine in the post-COVID-19 world. There's a really interesting summary of your background online. It's called Profile and Success. I read that. And we'll also post that here with this podcast if you like. So give us a shorter version of what motivated you into the direction of telemedicine.
So it was many things, Bob, but let's start with the fact that I'm the son of a doctor. And when I grew up, my dad was the only doctor in Dalton, Massachusetts in the late 50s, early 60s. So that was my formative impression of what a doctor is, a guy who tries to be everywhere all the time to this small town. When I got out of medical school, I was fortunate enough to have a Navy scholarship, and President Reagan was president at that point. I should say Ronald Reagan was president at that time. And I was in President Reagan's Navy. We went from 400 to 600 ships, and I was assigned to a ship, USS Mississippi, a nuclear-powered missile cruiser. And it's important. One, I got a lot of education around radiation, but also being nuclear-powered, we patrolled alone. No supply ships, no support vessels. And there were things that happened at sea. People would say a kid fell off a gun mount and injured himself pretty badly, or another young sailor had an appendicitis. I would have to call for help on the shortwave radio from the ship. It was, again, a formative experience calling back to the Naval Hospital at Portsmouth to get some sense of, okay, what do I need to do right now with this kid who's really hurt? When I left the service, I was released from the service in June of '88, and I took a sabbatical year. I worked on the Afghanistan frontier as a refugee camp doctor. Later that year, met my wife, and she was moving to Kenya, so we moved to Kenya, and I ended up doing some refugee work in the southern Sudan. That was an exceptionally dangerous job, but the concept was always the same. You have these places where there's no medical knowledge and no means to import it. When I finally finished my emergency medicine residency, I started thinking about starting a medical practice for ships, and the timing was right. The internet happened. This was around 1996. It was exciting in one breath. In another breath, it was so obscure. It's actually hard to imagine, but back then, talking about the web, people would assume you're talking about insects and spiders, but they would not think you were talking about some global communication network. I'm happy to report it's all gone well since then, in the sense that I've been able to build the practice, leveraging that connectivity as the web has matured. I've been able to sort of follow the curve. When I first started, I was a little too far ahead of the curve. That's a dangerous place to be, but I survived that mistake. And now it's kind of fun because the vast majority of people are carrying a supercomputer in their pocket called the smartphone. And we're using that smartphone to do things I couldn't have conceived of even 5 years ago.
From the entrepreneurial perspective, here you are with medical expertise. You've been in action in the field. You've seen the value of life and circumstances around that. But with no business experience, what prompted you to sit down and write a business plan? And this is like in the late 90s, this .com thing was starting to take off too. I'm sure that could be challenges.
It was all very challenging. My knee-jerk answer to your question was what prompted you? I would now say, 20 years later, sheer madness. Honestly, if you do not know how utterly impossible what you're attempting is, it's a lot easier to attempt it. So being a doctor, I thought, well, this is just a matter of reading more books. And goodness knows I've read a lot of books. But reading a book is not the same as writing a good business plan. And you can't learn management from a book. You can learn some of accounting from a book, but you really have to live it. So I'll be very frank with you. It was very difficult those first 10 years because the learning curve was so steep. And, I barely survived the tech bust. I went from 16 employees to 2 and restarted. But in retrospect, it was a blessing because that was the beginning of really being an entrepreneur. And the realization that entrepreneurs aren't afraid to learn anything to keep their dream alive. So I probably have about 160 some odd business books on my shelves, accounting, marketing, selling, you name it, management, public relations, and on, and lots of books about leadership.
Well, those are the things that we teach here at the School of Management. We have an Alliance for Physician Leadership program with just licensed U.S. medical doctors. And those things that you spoke of are exactly the things that we try to teach them, from quality to some of the information technology, the leading edge stuff that you use and things of that nature. But back to your business plan. What was your idea at the time? And it was somewhat of a niche market. Who was your target audience there?
Yep. So I looked at it. So I read a lot of history and I thought, well, where are you going to start? Because you have to make a living at this. And when I think about 20 years ago, 10 years ago, 2 years ago, insurance has never wanted to pay for telemedicine, whether it's Medicare, Medicaid, private insurance. There's never been an appetite. And certainly when I started, that was just inconceivable. So I looked for the one niche market that I knew so well, which was ships. And I knew there was a need. And I also knew that in the super yacht market, these are big private luxury vessels, there was also money to pay to have a doctor on call. And so that's really where I started. I wrote a lot of articles for super yacht magazines and sailor magazines and tried to build a reputation as a sort of a planning expert, getting your boat ready for sea, et cetera. As it turned out, that was very fortuitous because as I became known to our initial client base of super yacht owners, they would do things like sell their boat. And they'd come to me and say, hey, Dan, we're selling the boat. But, we still have 6 homes and we're in 3 countries. We really want you to just take this over, be the guy we're going to call, have your team make our appointments, organize our insurance in the country we're in. And that was actually a transformative moment because we started moving away from purely super yachts to actually more of a global infrastructure and a personal infrastructure. Now, Bob, bear in mind, 2005 is about when this started. There was no such thing as concierge medicine.
Yeah.
Like that phrase hadn't even been coined yet. So people would say to me, so what do you do? And I would struggle to tell them that I was actually a distributed, intelligent medical system that could deliver and pay for healthcare anywhere in the world on a moment's notice.
What would you typically do for that high net worth client? You're working with family offices, you're working with the top leadership folks in companies. What would you actually be able to do for them that they found so attractive at that time?
So in the beginning, it was very much about acute care, meaning the client has taken a fall on a ski slope in Aspen and had a wobble in his left lateral visual field. And he was behaving and acting a lot like a torn retina, right? Retinal detachment. So I, as a boarded emergency physician, said, holy cow, this is a retinal detachment. Don't move, no aspirin, no alcohol, keep your head up. But then the second move is, so where is there an ophthalmologic surgeon to repair this? Because we sort of have a deadline here. We need to move along fast. So it was the front end was acute care. The back end was organizing resources where the patients were. That was the very beginning. So when it turned out to be a very good preparation for what was to come. One thing I never thought would happen was our clients would never leave, meaning they would get used to this idea that a doctor would answer the phone that knew them, had their records, and they were starting to grow old. Now, between you and I, it's 20 years later. I am 60 years old. I started this when I was 39, right? But so are my patients. And we've moved from, falls while skiing in Aspen to chronic diabetes, Parkinsonism, atherosclerosis, and on and on and on, the diseases of aging. Atrial fibrillation is a big one for us. And we've now broadened the practice scope to do a lot more chronic care. And here's where it's really interesting, because it's not easy to do chronic care without having a smartphone. And I'm not being facetious. There's a bunch of really clever devices out there now that can monitor heart rhythm, blood pressure, sleep patterns, even depression. And the phone serves as the portal to collect and distribute the information to physicians like myself. So we have patients under management, say for congestive heart failure. We had a patient, this is a true story. This man was a pilot at the Battle of Midway. Okay? Just to give you some idea of where he's coming from. Right. He acquired congestive heart failure in his late 80s, and he was really struggling with it, readmitted to the hospital multiple times. And I convinced his son to let us take over his healthcare. And we basically said, look, there's 3 metrics around your dad's congestive heart failure: his morning weight, his heart rate, and his oxygen saturation on a pulse oximeter. So every single morning we would collect those 3 data points. And he was not readmitted to the hospital for the rest of his life. He ended up dying of other natural causes, but he was not readmitted to the hospital. In fact, he lived to 96 years of age.
Wow. That's
the big thing that people say, hey, Dan, what's the next thing coming? I'm like, that's what's coming. Smartphone-enabled chronic care is going to be huge.
So what's really unique about your care model? What kind of differentiates it? And following that, how do you scale this thing? How do you scale it from, high-level executives and family offices to a broader audience? Is that the plan?
Yeah, that is the plan. And it's already well underway, and I'll get into that in a second. But let's talk about what's unique, just for starters, because I have to give a nod to the folks in the phone a physician industry. These are companies that, they're often partnered with your insurance plan, where you can call a physician for an urgent care problem, a minor problem, and physician will give you some instruction as to what to do next. It's not very high quality in the sense it's not continuous. You don't speak to the same physician every time, and they absolutely don't have your medical records. But they introduced the concept of speaking with a physician or video conferencing with a physician as a first step. So we've taken that first step and said, okay, let's make this a real practice. Let's bring continuity to it, informational continuity. Let's behave like a medical practice. Let's get very accurate medical records. And when you see another specialist, let's get those medical records and get them plugged into your home kind of archived medical record here. That is probably the biggest step that I've seen, is this kind of evolving from simple urgent care to everyday medicine. So you're still doing acute care stuff, still doing urgent care stuff, but you're doing a lot more chronic care. And because you're now accountable, you're making sure that every journey ends happily. So when I send someone to an emergency room, for example, a copy of the patient's medical record gets to that emergency room, or me or one of my colleagues will actually speak with the charge nurse or the on-duty physician and say, here's what I'm sending you. I'm the physician of record. I'm going to give you context and background, because I want to make that physician's life easier. But more than any other priority is we hold ourselves accountable for the final outcome. And that's really the big.
This episode is brought to you by the Center for Healthcare Leadership and Management, the definitive resource for healthcare management education in North Texas. The center is based in the Naveen Jindal School of Management at the University of Texas at Dallas. It plays a unique role in training the next generation of healthcare leaders to meet local, regional, and national demands. The Jindal School uses its strengths in accounting, administration, finance, marketing, and information systems to educate highly qualified personnel for healthcare administration and executive leadership positions. The center is home to 7 healthcare leadership and management programs, including undergraduate and graduate programs, as well as executive programs for physicians and working professionals. For more information, visit us online at jindal.utdallas.edu/healthcare.
You stop and think about telemedicine. Recently, I went out and looked at some of the doctor registries around town, and they all now say telemedicine is available. The local doctors are all putting that on their websites. All of the directories for doctors, they state now what their hours are when they're open, and also telemedicine available. So the general telemedicine practice, how does that differ? That continuity of care, I don't get the sense that if you go in for certain things with the telemedicine, it might be less expensive. I might be able to see a doctor. I might be able to avoid waiting in a waiting room. And the whole concept of waiting kind of gets diminished. But going deeper than that, I don't think I would get referrals and more follow-up and things of that nature. Is that different in your organization?
Well, we pride ourselves on the whole accountability and continuity. With regard to the late adopters, and that's what you're talking about, Bob, is the guys who just got here and said, hey, our patients want this, so let's get it. There's a very broad range in quality of the care rendered telemedically, if you will, and the continuity of information and how well integrated all the different elements are of the medical records and pharmacy services and all of that. But I can't be too negative about it because this is an incredibly important inflection point for telemedicine and indeed kind of the history of medical practice. This is all happening right now where we're converting from a bricks and mortar office model to a smartphone connect you with my app model, sort of an app first model, if you will. This is huge. This is huge because now what you're starting now to build what in other industries they refer to as a distributed service system, where they distribute, for example, consumer retail. The distributed system is Amazon. It pushed consumer retail right down to the buyer at the laptop level, if you will, or the iPhone level. This is now the beginning of a distributed medical system, but we're going to basically push healthcare down to the level of your smartphone. So I can't be negative about it. I can gloat a little bit because they're late adopters. I wish they'd been early adopters, or I wish they had made fun of me 15 years ago. But boy, I'm glad it's here. I'm really, really glad it's here. This is a moment in history for medicine.
Okay. Thinking about that, a moment in history for medicine. You've been at this for 3 decades, passionate about it, evolving it as you've gone along. If I understand it as, if I subscribe to your service, I want to kind of understand what my environment would be like. But I'm getting the impression that I make a phone call and very quickly I'm connected in with someone who knows everything about me. And no matter where I'm in the country, if I'm up in the mountains of the Alps and I get hurt, people know how to get a hold of you. It seems magical to me that I could actually connect with someone remotely. That's usually the time of panic and major concern. And that this is not involved with the insurance company or anything like that. Kind of make it real. If I was to be a subscriber of your service, what my expectations would be and how do I manage through all that? Sounds fairly complicated to me, but you say it's very simple.
On the back end, it's complicated. It require a lot of very smart software architectures and such. But for the patients and the doctors, it's pretty darn simple. And it was designed to be deliberately simple. We never wanted to get ahead of our patients' understanding of how to use the right technology. So where we are now, right now, super clear. Our app goes on your phone. When you open that app, you have a series of choices. At the very top is the button that says call a doctor. And there's other buttons like what's in your little prescription medical kit. All our patients carry a medical kit. And there's other things, first aid, or I want to talk to my care team about some logistical thing. But honestly, it's really about tap that first button, call a doctor. That goes to our call center. An operator, very pleasant, answers, takes your name and your phone number and says, stand by, I'll get you a physician. And it takes about 35 seconds. We have a doctor on call. We have a doctor on second call. We have a doctor on third call. And that physician answers the phone and says, hi, Bob, how are you? The next thing he says, though, is kind of magical. He says, Bob, I see you're calling me from Dallas. What's going on? When you placed the call with our app, we geolocated you, and you're now a little blinking blue dot on a map of Dallas, Texas. Okay? And on that map are all the hospitals around you. They've been flagged in their capability. All the 24-hour pharmacies around you. They've been flagged, as well as I can also search it for example, where to get your blood drawn, like a Quest Labs or LabCorp or something like that. But we're able to place you in the context of all the infrastructure around you. So you and I are talking and you'd say, hey, I've got a bad sinus infection, or actually, I'll give you a really good case. This just happened. I've been stung by 2 bees and I'm allergic to bee stings and my lip is starting to swell and I'm a little lightheaded. So in that case, I say, okay, Bob, open your medical kit. And is someone with you? And say, yep. Take out the EpiPen, clean off your thigh, soap and water real quick, and you're going to EpiPen right now. And we've done that a couple of times over the years. And EpiPen is an EpiPen. It works. But I just bought you 35 minutes against an overwhelming allergy, which is enough to give you the Benadryl out of the kit and the prednisone out of the kit. Because my goal is when you finally do get to that emergency room, it's not going to be a very long visit. I wanted to buy you that hour or so. So that's what it feels like to the patients. And like I said, where it gets really interesting is they can now text us securely. The whole platform is beyond HIPAA compliant. It's like bank level security, even beyond that. And you're now in a situation where they're in almost, I wouldn't say constant, but daily, weekly, you're communicating as frequently as they want to, via text, with the care team that takes care of them, with the physician team that's tracking their active case. It looks a lot like when we were young doctors making rounds in the hospital. When you were an intern or a resident, you had a service of actively ill patients, and you were telling each other what was wrong for the person who was going to cover overnight. That's a lot what it's like. You're constantly talking about what's going on with the patients, typically 2 to 3 times a day.
So it's probably an understatement to say that telehealth is really booming now. And COVID-19, you alluded to earlier, is that it really helped move this whole concept of telemedicine to center stage, really put it in the spotlight. And I've heard you talk before about an Uber business model for telehealth. Explain to our audience what that means.
Yeah, sure. So the Uber business model for telemedicine is the teledocs, for example, or doctor on demand. These are basically what I call phone a physician services. They're companies that built the platform to connect the physicians who want to be on call and get paid for it with patients who want to make a phone call and get some element of medical care. So it's a lot like Uber. I need a ride. I open my Uber app. It locates a driver. He comes and picks me up. Very, very transactional. And then it's done. Like with Uber, I never expect the same driver to pick me up tomorrow or later on the day, but it'll be another Uber driver. But it's very one-time transaction. That's what I mean by the Uber model in telemedicine. And again, I'm not going to say anything negative about it. I'm going to say thank you for moving the industry forward because you made telemedical access simple. I wanted to return quickly, though, to the COVID comment you made because it dovetails into another thing we're working on. So earlier you asked me about kind of scalability and moving down market. I started a second company last year that does telemedicine to construction sites. And now we're moving from hundreds to tens of thousands. And we're taking care of injured workers, people who are sick at work. And we're doing a great job on it. And then COVID came and, oh my goodness, our volume of cases and calls went up 8-fold in 1 month. And it was abundantly clear that we were going to literally have to develop our own COVID screening protocols, symptom screening protocols in particular. We never saw that one coming when we started this, but it's been a huge success for the employer and the employees in terms of protecting them, keeping them safe, but also keeping the job sites open. It was an inadvertent validation of, yep, this is really scalable, but you have to do the dirty work. You have to kind of march through a lot of processes. And we're blessed with a gifted CTO who's very patient with us doctors, which is not easy. And we kind of tell him our problem set and he looks at me like, you people are illogical. But we eventually sees our logic and you build these things. And like I said, we built this for COVID. So there's no doubt in my mind that telemedicine is going to scale now. And, we were in a tiny niche market with the only guys who could basically pay us for me to make a living 20 years ago. But now it's coming down market. We're talking to some self-insured companies that have kind of had it with their local healthcare system. They want someone on their side. And I think there's going to be even more of that.
Is this really shifting your business more to risk management?
Without a doubt. We've been in pure healthcare for families, the tops of corporations, and very remote island and ship populations. We were there forever. Now it's really all about risk. The construction firm wants to know their injured workers are going to get really, really good care, and they're going to come back to work recovered as quickly as possible. That obviously is wonderful for the worker. It's also very good for their employer because they're ultimately going to be paying for this care one way or another. So that's an element of risk management for the self-insured companies. This is going to be a huge deal. If a lot of companies, most companies more than 200 employees, essentially set aside a couple $1 million into a health captive fund, and they pay their claims out of it. Our system has gotten very good at extracting billing codes out of even the most minor medical visit and generating a large bill as a result. These employers have kind of had it with that dynamic, and they want a physician group on their side that's going to make sure their employees get great care, not be a gatekeeper, not be a price controller, but decide what's reasonable and what's appropriate. And can it be done quicker? Can it be done cheaper? Can it be done more efficiently? I'm certain this is going to happen. And we're getting calls to do it, and we're not ready to do it. Our hands are full with what we have. But by next year, I'm certain we'll have probably 1 or 2 pilots doing this for self-insured companies.
Well, I'm sure that as a recruiting tool, I came from industry and, Fortune 10, Fortune 15 companies, recruiting top executives, that would certainly be something that you'd want in your management profile, to be able to make sure you can take care of your top people, that they're on the run all the time. They're always going, and all kinds of bad things can happen. So you want to basically put them under your umbrella and make things work forward like that. Recently, McKinsey published a survey on telemedicine and COVID-19. I wonder if you had any comments on that. It kind of speaks to the fact, and we'll post that link out for this McKinsey survey, but it seems to indicate that this is really a new engagement enabler. Just the fact that people are being exposed to having to use this, it opens their eyes to the deeper potential in further application. And you mentioned a lot of these high-tech devices. They have defibrillators, and they have assistant programs that look at your diabetes and things like that. Are you incorporating that into your high-tech toolbox as well?
Yeah, we are. We're starting to. When we find a really good device, like I said, a number of our patients are really aging now, where we've got to really stay on top of little things like heart rhythm, body weight, blood sugars. We're using these devices. They're generally actually reasonably inexpensive. They can pair to the iPhone. The manufacturers will have an API that you can use as a bridge to bring it into our informational databases. We write custom reports, so I can, let's say, look at your blood sugar for the last month, your average blood sugar, your highs, your lows. I can ask it which day, which time of day, all of these things. And it helps us to really tweak management. In my opinion, and I think it's a valid one, this is far better than having you come back to the office with a handful of sheaf of papers with your blood sugar readings written down. And, there's opportunity for error, or not such great data is there. So technology is happening, no question. This is going to roll forward. And the McKinsey study, what they really nailed was COVID has basically pushed telemedicine into the mainstream. People know they can't go to a bricks and mortar office now, and they're being forced. I hate to say it, but that's kind of what's going on. They're being forced to adopt this new way of accessing medical care. And I think this is a catalytic moment. It is unlocking the industry, literally. I couldn't have imagined the progress we've made in the last 11 weeks versus the previous 20 years, Bob. It's unbelievable. It's really exciting.
Well, I know your idea is to put the doctor into the palm of your hand, yeah. And you've got an app like that. In the back of my mind, I think of some of these big tech players that have to get involved in healthcare, like Google and Apple. And I certainly think that that's the technical side of it, but the process and quality and all the other items that go into the soup, you have good insights on. So they ought to be knocking on your door, I would imagine, saying, how do we scale this thing? Early on, I'm sure it was an expensive item for someone. with this going up in scalability, does the cost of using your system start to come down as well?
Yeah. It's the bigger the numbers, the lower the price. When we started, literally 20 years ago, the idea of a global personal medical infrastructure was $20,000 per person per year or per family per year. Now, honestly, it's around $4,000 anywhere in the world type thing. When that's a product we sell for when people are traveling. I think it's going to fall into the hundreds of dollars.
Wow!
In the not very distant future. For example, for the construction, we have 9,000 construction workers that we're caring for. That's on the order of $130 per worker per year in the current budget, and that's to take care of that entire workforce for any injury that occurs at work. So I think we're already there. It just depends which application, what you're trying to do, what kind of care you're trying to deliver.
Okay, I'm going to shift here a little bit. In closing, I know that you publish a blog and you post a look at what's actually changed about the drivers of COVID-19, and you clarify some of the new updates. There's a lot of, well, we could just go on and on and on about some of the latest topics along that line. So what is just one of the latest pieces of information that you'd like to share with our audience today?
Thanks for asking that. If I could leave the audience with one concept, all right, I'm going to stretch it to two. The first concept is testing has been historically not so helpful. Old-fashioned kind of clinical medicine, asking symptoms and making a decision, that's been helpful. Okay, so let's just put that away. Testing's not been very helpful. But the second thing is, and this is really, take this one to the bank. When you want to understand COVID and contagion and being infectious and all this, you understand the concept of viral atmospherics. And what does that mean? It means the number of viral particles in the atmosphere you breathe. If you look at who's died of COVID, they've almost all been in high density atmospheres of COVID, meaning nursing homes with closed windows in winter, concentration of COVID virus. Who else got it? Healthcare workers in nursing homes with COVID. And who else got it? Family members of the healthcare workers. This happened in late winter. So all the windows were closed at home. All the windows were closed at work. People were shedding virus. People were breathing in virus. But these were high density environments. So when you think about, hey, what's my risk for COVID here? Ask yourself, are the windows closed? Has there been an outbreak of COVID cases in the place that you are? And make a judgment right on the spot. Say, for example, you're about to go into a restaurant. Are you going to sit outside or inside? Personally, I would tell you to sit outside. Sit outside in the fresh air because viral atmospherics are going to be much, much lower than if you're inside where we're all breathing the same air. And by the way, that applies to spaces that are air conditioned too. It's not just about it being cold outside. It can be too hot outside and now you're all inside the air conditioned space. But again, you're rebreathing the same dense air.
Well, thank you for that insight and advice on that. As I mentioned at the top of the podcast, we could spend hours with you. So thank you, Dr. Dan Carlin, founder and CEO of WorldClinic. You've been a proponent of telehealth for decades. The best to you and your WorldClinic team as you continue to unburden and improve the healthcare system. It's been a delight having you on, and we look forward to touching base with you again in the future.
Thanks, Bob. I'll look forward to it too. Take care.
Thanks for listening to the Business of Healthcare podcast. Join us online at businessofhealthcarepodcast.com to find episode links, notes, and more. Be sure to subscribe to the Business of Healthcare podcast on Apple Podcasts or your favorite podcasting app. To learn more about the Center for Healthcare Leadership and Management, go to jundal.utdallas.edu and then search under the Center and Institutes tab on the navigation menu. Also, we want to hear from you. If you'd like to provide feedback, make suggestions for future guests or show topics, or just want to get in touch with us, email us at healthcarebizpodcast@utdallas.edu. Biz is spelled B-I-Z. And let us know how we're doing. I'm your host, Dr. Bob Kaiser, with the Center for Healthcare Leadership and Management, where we're leading change by changing how we lead.